This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
Hello and welcome to Daughterhood, the podcast. I am your host, Roseanne Corcoran, Daughterhood Circle Leader and Primary Caregiver. Daughterhood is the creation of Ann Tumlinson, who has worked on the front lines in the healthcare field for many years and has seen the multitude of challenges caregivers face. Our mission is to support and build confidence in women who are managing their parents' care. Daughterhood is what happens when we put our lives on hold to take care of our parents. We recognize this care is too much for one person to handle alone. We want to help you see your efforts are not only good enough, they are actually heroic. Our podcast goal is to bring you some insight into navigating the healthcare system, provide resources for you as a caregiver, as well as for you as a person, and help you know that you don't have to endure this on your own. Join me in Daughterhood. Dr. Kalisha Bonds-Johnson is an assistant professor on the Tenure track at Emory University's Nell Hodgson Woodruff School of Nursing in Atlanta, Georgia. She earned her BSN, MSN, and Ph.D. in nursing and specializes as a family psychiatric mental health nurse practitioner. In 2019, Dr. Bonds-Johnson earned her Ph.D. from Oregon Health and Science University, where her studies focused on how the caregiving experiences of African American dementia pairs, that is, African American persons living with dementia and their African American family caregivers, were associated with their quality of life. In our conversation today, we discuss her past and current research regarding African American dementia caregivers and their care partners, the challenges of accessing needed services, the disparity in healthcare, and the important need for support. I hope you enjoy our conversation. Alzheimer's and other dementias affect African Americans at higher rates than other ethnic groups, yet African American older adults use fewer formal services. Your research looked at that through three sectors: formal services needed, expectations of formal service providers, meaning the expectation that the primary doctor would be the initial contact and be able to provide guidance to services, and formal service. What were the results of your research?
It was interesting. So we took a lot of articles, and to give everyone context, formal services just basically mean healthcare services in the gerontological or older adult research. That's just one of the researchy terms we use. Formal services just means it's not informal. So it's not family. It's coming from a healthcare system typically. Okay. And so for the African Americans across these studies, I think it was 14 studies in the research that I did, the main sort of themes that came out was that there is this formal service need. As you mentioned, there are these expectations of these formal care or healthcare providers. And then how much of this formal service is actually being used? And caregivers want formal services. They want healthcare services. They want these things, which was kind of this, maybe not controversy, but this concern in the literature was like, is it that African Americans don't want these services? And so that's why they're not seeking them. But it did come out that they want them. They recognize that they need them. And sometimes, depending on the characteristics of the caregiver who is seeking these services, they tend to seek more or less. Mm-hmm. And then the expectation really did come out is that they wanted physicians to sort of be a part of the team and really have insight on their choices and what decisions they make. And we know the healthcare system's not set up like that. Yeah. Like you might get 15 minutes with a healthcare provider. Right. So to say, here are your choices, like whatever that decision is, here are the options. now let's decide in this time what we want to do. And again, you might have other family members that weren't able to attend the visit. And so you're wanting to pull the whole team together. And that just isn't how healthcare is set up.
No.
And then lastly, when we think about formal service use, like it did sort of depend on the health caregivers. So those family caregivers that felt like, they had a lot of caregiver mastery, they seem to feel pretty confident in not necessarily seeking services. Mm-hmm. And so this paper really is sort of where my work is going now, with this idea of we really don't know what is driving the limited use of healthcare services for African American older adults and their family caregivers.
Okay. Well, and it's interesting because we know that there's a disparity in healthcare.
We do. We
know that.
Mm-hmm.
I mean, from thinking that pain tolerance is different to kidney functions are different.
Yes.
So there's a different level that it's almost like viewing two separate medical fields.
Well, it's convenient.
Yeah.
Only when it's convenient.
Yes. Okay.
We're two totally different species, almost at certain times. So they couldn't possibly feel Black people, African Americans, and I'll probably go back and forth between those two. But as we were talking earlier, when I think about African American, I am speaking about individuals of African descent who lived in the United States and also had enslaved ancestors. When I say Black, I'm thinking about the whole Black diaspora. So those are individuals who may have immigrated here, live somewhere else. Often their identity is stripped when they come to America because they are assumed to be African American.
Right.
But there is sort of this different lived experience. And when you ask different scholars, they will probably give you different answers, but that's just my little 2 cents. But I said all that to say, the idea that African American skin must be so much thicker than non-Hispanic white skin, so they don't feel pain the same. But when you think about how different things in modern medicine were formalized, tested, we think about Marion Sims in gynecology. He perfected different procedures on Black enslaved women that he then used on non-Hispanic white women. So the concept was we weren't two different species then. When we think about Henrietta Lacks cells with cancer, we weren't two different totally, I don't know how the two could be the same. So it's almost like the healthcare system, the powers that be, the policies and practices at play work to benefit the majority all the time. And for those of us who are not of the majority racial or ethnic group, we are used to benefit the majority, even if it's at our detriment. Sort of under the guise of, they're different. They're slightly different. And no one has been able to scientifically show that we're different. But because of those differences in lived experience and how one is treated when they enter a healthcare system, I think that's where we get a lot of the difference that we see in the health disparities.
Absolutely. And I think it would prevent someone from seeking that out as well.
Yeah.
Because if you know you're going to be treated differently, it's not like you're going to go running in there and be like, hey, could you help me? You already know you're not going to be helped.
Right.
And that's a barrier in and of itself.
I agree. I think it is for sure. And so that's why the work I'm doing really is sort of, let's go to these adult daughters who are caring for their parents who have some forgetfulness and see, are you seeking healthcare services? Are you or aren't you? And if you're not, then why not? And is there something that we can do, be it the healthcare system or empowering these adult daughters to help them with navigating the system more effectively for a parent? Because I'm going to tell you, I'm a nurse. I know the right lingo. I'm a nurse practitioner. I know how to talk the talk. But going into appointments to assist my grandmother who raised me from almost birth, I was 2 when I was placed in her custody after my mom passed away, recognizing that I know how to talk to her doctors. I know what to say. I know what questions to ask. I know what resources to mention. So I have a little bit of a leg up in navigating that for her is what sort of made me think, what about the families that don't have a nurse, that don't have a Kalisha in their family? How are they navigating this? Because, even as a clinician, I'm like, spouses, you pretty much get access. You can look at charts, you can add, you get a lot of access to one's providers. If you're taking your child into an appointment, a lot of access. As an adult daughter or an adult son or nephew, or trying to navigate care for an adult, for a parent or an uncle, there's so many barriers
at every turn. And
we don't make it easy for you.
No. And it's when you're caring for a child, it's like everybody wants to help. This is my child. This is the situation. What can we do? Oh, you've got this, and this. But when it comes to caring for your parent, because they're older, it's like, well, no, we don't. Oh, they got old. It's not, we can help in this, and this. It's, well, they're old. What do you expect? And that's horrible. It's horrible.
As a society, it's like, oh, you got old. You'll fall off the cliff. Hope someone's there to catch you. Hope your family has money and time and resources, because we don't have much for you.
No. And nobody, and, to think of the cost and how much it costs, it's nearly impossible to save for it. And the amount of money that it costs per month is more than people have paid for their mortgages in their houses all their lives.
Yes.
And then everybody thinks, well, you just run out of money and you go on Medicaid, which is, you get what you get and you don't get upset because, this is what we have. This is all we can offer you. And by the time you get to that point, it's too late to bring anything else in. Like I said, I love all of your research is riveting to me. And what you found especially with dementia caregiving, and, dementia caregiving is a different meat grinder. It's different. There's so many different levels of it, from the change in the relationship between the two of you to the changes in your care partner. What you found, which was interesting, was the relationship between the people, and when you involve your care partner in the decision making, it seemed to help. Can you talk to me about that a little bit?
Yeah, so I was really interested in just focusing on this sample that I was given from Dr. Carol Willard out of the Benjamin Rose Institute, of these African American dyads is a word I use a lot in my work, which just means two. And here I'm using it as two people. So it's the person living with dementia and then their care partner or family member who is assisting in that care. And so I was really curious to see what was happening in these relationships. Like, did it matter? Was the quality of life affected? And so I definitely wanted to look at sort of the idea of, does it matter if you're cared for by a spouse, or are you cared for by a non-spouse? Is I think how I broke it up, because I didn't have enough to tease out into daughters and sons and that way. But daughters, sons, nieces, grandchildren were like non-spouse, and then you had spouses. And then I was also curious in what we called daily decision making. So it was things like what time I'm going to go to bed, or what clothes I'm going to wear, what I'm going to eat for breakfast. So it was involving that older adult in the decision making, and that comes from our own lived experience. So my grandmother started taking care of me in her 50s when I was 2. She's now almost 90. She probably will not be thrilled when I say that, but she'll be 90 next year.
God bless.
And I've learned I can't make her do anything.
No.
First of all, it would be so disrespectful to force her to do anything she didn't want to do. So I was really interested in this idea of how involved can one stay, even when there's forgetfulness, even when there's cognitive decline, even when there's dementia. And then also what that relationship quality might look like. And so, as you alluded to, the adult daughter, that's where I go now. The non-spousal caregivers, again, predominantly adult daughters, but a few other relationships mixed in, had worse quality of life and the person they were caring for when compared to the spousal caregiving pairs or dyads, which is not what we typically see in the literature when we look at the non-Hispanic white couple. for them, it's typically that the spouses were having a harder time, and they equate that to longer hours caring for the person and being there more consistently. But for these non-spouses, they were having a really hard time. And also, when the person living with dementia didn't feel like they had a say or a voice in that decision making, that sort of daily decision making, they also had worse quality of life. And then when the caregiver reported more dyadic strain, so more issues in that relationship with the person they were caring for, they also had worse quality of life. And so this is interesting. I might be onto something here. Yeah. And so I started looking more intentionally at caregiving. Because, there's lots of research about, African-American, Black caregivers, non-Hispanic, white, or Caucasian caregivers, and Asian caregivers, and Hispanic caregivers. But there wasn't a lot of drilling down to see what these caregivers look like. What's the makeup? And when you start looking at African-Americans, they're predominantly adult daughters, middle-aged adult daughters. Mm-hmm. So you're not done with your career. You're often still caring for someone other than your parent. Mm-hmm. Financially, you're not in the same place as when you think about these non-Hispanic white caregivers who are typically spouses, who are probably often at retirement age or really close to retiring. And so just the financial trajectory would be different. The life goals, plans, the day-to-day happenings, all of that's going to be different. But we really haven't taken the time and research to tease that out. We just kind of compare caregivers across the board and say, well, these are doing better than they are. And then one thing that comes up consistently is African Americans seem to have a lot of positive caregiving experiences. Well, it's really hard to say, this sucks, mom and dad. Yes. It's a lot easier when it's your spouse to be like, this really sucks, and I don't want to do this anymore. I can tell my husband all those things. Right. I'm not going to tell my grandmother that.
No, of course not.
It's true.
I don't think she'd take kindly to that.
What? Sorry, I had a moment. Let me get myself together. Where if my husband said, what, you heard me, do I need to repeat it? It's just a different dynamic.
Right. Well, and in the African-American community, with knowing that we're not going to be helped, we're it. So we're
all we got.
We're all we got. So you tighten the reins and you're caring. So it's harder, I would think, and I believe your research backs this up, to reach out for that help.
Yeah.
Because what do you do? And then even if you do reach out for that help, are you betraying, for lack of a better word, that system that you're in?
Yeah.
And how does that shake out?
I'm still figuring out how it shakes out, but you're right. I, as you were talking, it made me think about one of the daughters I interviewed for my current study. Mm-hmm. She has placed her mother in an assisted living, and it's a swanky assisted living. I mean, I think she is paying, if I had to guess, probably $10,000 a month.
Easily, yeah.
Easily. Yeah. The South, is a little more generous when it comes, rent, mortgages, right, and other regions of the United States. But still, easily she's probably paying that. And her mom's friends have told her, basically they're not happy with her. And I can't believe you did that to your mom. You're supposed to be taking care of her. And she said, if I take care of her, this is what she told me. I don't think she said anything to her mom's friends. She just kind of accepted it. Right. But she said, if I take care of my mom, then I can't work. And if I can't work, then there's other things I can't do. I think her mom financially had some really nice resources set up. So most of her mom, I think the majority, if not all of her mom's retirement or and different resources is covering all of her mom's things. But she's like, what about me? How would I live? How would we survive? I wouldn't be able to get mom any extra things, And so she said, if you could fix one thing, the African American community, can you fix that? I don't know.
Right.
How can we change a community's view of, because it's not a nursing home, but people think, all long-term care facilities are the same, and they're not. There are differences amongst them.
But in their view, that's what they see. They see, well, she's not with you, therefore
she's not with you.
You're not.
You failed her.
Yes.
You are not a good daughter.
Ugh.
And that pressure.
Yeah.
That societal pressure, because that's across the board. I know I've talked to all races and not all, but several races and ethnicities. And across the board, society-wise, women are expected to be the caregivers.
Right.
But then if you add in discrimination and racism and sort of this other thing where my own race, my own people, my own community are looking at me negatively, because I don't think y'all have that as much. I don't think there's that sort of extra in the same way.
Not in the same way. I believe you're absolutely right. Not in the same way we don't.
And so you think about all that pressure to hold it all together.
Yeah.
Which is why when we look at the health outcomes of African-American caregivers, they're not better than non-Hispanic white caregivers. We might have more positive aspects of caregiving.
Right.
But financially, we're struggling more. Our health is deteriorating more. There are just things, the body keeps score, I think is that book.
Yes, it is.
And it does. And so I've been really interested in this idea of the strong Black woman and the superwoman schema. And there's been several authors. I think, I don't want to misquote, I think Jessica Abrams was one. And then Cheryl Woods Giscombe is another one, who have really been sort of taking this idea of, as a Black woman, and I'll probably go between, because the researcher in me is supposed to say they, but the Black woman in me is like us.
Right.
Right. Who knows what pronoun's going to come out at any given time, but really just this idea of I need to do more. I got to hold it all together. The family is riding on me to do this. And so I have to be strong for everybody else. I'm not putting my mask on before I'm securing someone else's mask. And so are there ways that we can unlearn that? Is there a way that can be unlearned?
And do you think there is? Have you found that yet? Or is it so, and listen, it takes a long time, right? Any kind of systemic change in anything takes a long time.
Yeah.
But do you think that there's a foothold for you, a foothold to get in, to be like, we can change this? Or is it so totally ingrained that it's just there?
I don't know yet. I don't have enough research to know. I'm hopeful. I mean, I think, the one thing about when you do what we consider intervention work, so there's a place where you want to intervene or something you want to change. Some things you can't change. Can't change your age, can't change your race or ethnicity. Gender is kind of fluid now, so some might say you could change that.
Right.
But things like having too strong of a superwoman schema or strong Black woman, I mean, I would hope that might be something we could mold or change, or at least recognize this is why I do what I do. Is there a way to rethink that? Or, maybe it's, I just don't have the right language. So if someone would teach me the right language, then I'd feel more confident in these hospital settings and these visits, and I'd be able to get my needs met. Because the other thing is, you do have to have the right language. Like, healthcare professionals are taught a certain lexicon, we got a certain way to do things. And if you can just tap into the right words at the right time, not related. I had a family member who reached out or put something on Facebook, and I said, call me. And we were talking, I said, this is what you need to tell them. I talked to a colleague, as I'm psych. This was diabetes and heart stuff. I do mind stuff, sleep, appetite, psychosis. I can help you with those. Hey, these other things, toes and skin and hearts. I don't know. I'm like, I wrote it out. Like, I texted to him, this is what you say exactly to the paramedics. And when the paramedics got there, they said, well, technically she doesn't seem as bad as you said she was. But because you said what you said, we're going to take her to the hospital anyway. And so really there is this unknown language that I think we could teach people. Say this instead of that. Ask it this way instead of that way. Not that I don't think we're trying to be secretive. I think it's not common language.
Well, I think it's because there's so much that goes on. And when somebody's starting, you're going through the whole story from 1995, and it's like, no, you've got to hit the high points.
Yes.
And that it's like the magic words. You need to know the magic words because that's what they're listening for. And once they hear it, then it kicks them into the next step. Oh, okay, then we can do.
Exactly.
But the problem is when you're caregiving, you're so focused, and usually there's something going on. You don't usually just go in like, oh, hi, we're just here, say hi. Like, you're going in for a reason, and you're already upset. You're already stressed out. You're probably sleep deprived. You probably haven't eaten all day. And, like all of these things are on you. And then you have to be strong for that person and keep it together for the doctor, because then they're going to be like, oh, can't talk to her.
Right. And a little performative. You also have to perform a little bit.
Yes.
Because you can't come across as neglectful.
No.
Black women can't come across as too angry, because that's a whole thing.
That's a whole different, yes.
So there's these things you kind of have to show up a certain way. And if we had a cheat sheet,
right,
to give these African-American daughters, so they know how to navigate the healthcare system for their parent, why? Of course, let's give them a cheat code. So that's what my research is trying to do. It's trying to figure out the cheat code. So right now,
I love that.
Just came to me. See, you just created a space of creativity. Thank you so much.
You are welcome. Happy to help.
Yeah, so no, I'm actively recruiting right now, probably for the next year, depending on how quickly I can get these dyads, these pairs into the study across the United States. So I am looking for African-American adult daughters who are assisting a parent. It can be a parent-in-law, can be a fictive kin parent, but assisting a parent who has some forgetfulness. I have a pre-screening survey that the adult daughter typically is the one that goes online and completes really quickly, takes about 5 to 10 minutes. From that information, someone on my research team contacts you either by email or phone to say whether or not you're eligible. And if you're eligible, then I interview you and your parent. I know, makes people nervous when I say the parent. You want to interview my parent? Yes, I do, because I have handcrafted about 20-minute survey, 20-minute visit of surveys that I think your parent can complete. If we get to a survey they can't complete, fine, we skip it. If we get to a question they don't know, they don't understand, we skip it. So the idea is that during that visit, it's the adult daughter present with the parent. I've discovered it works well that way. There are 10 questions where the parent gets to answer questions about their relationship. So I let the daughter know in case the daughter wants to leave the room, so the parent can have the privacy to discuss that without feeling watched or judged.
Mm-hmm.
And then after that 20-minute visit, unless the parent's really talkative, and sometimes it's been an hour and a half visit, because again, how often do these older adults get someone that's like, I just want to hear from you.
Right.
Tell me, it's Likert scale stuff. So agree, disagree, yes, no, true, false. And then after that, I email the interview to the questions a little longer, about 40 minutes for the adult daughter to fill out. And usually we do it over Zoom. They fill it out in that Zoom space. So I'm there in case the daughter has questions. I usually block about 2.5 hours, because technology is great when it works, but when it doesn't work,
not so much.
Not so much. Or if your parent's really talkative, I don't want to blow up your schedule and you're like, I only blocked off an hour and it took an hour with your mom.
Right.
So it's a one-time thing. They get $25, both of them, for their time as a gift card. And then I'm hoping to collect that information from about 70 pairs. I'm about a third of the way there. And then with that information, we're going to crank out the numbers, review the transcripts, do a little bit of work, analyze that data, figure out what's shining through as areas that we might be able to intervene on, working with what I'm calling some key informants, so some people who have skin in the game and have been doing this for a while, as well as the community advisory board that's associated with my lab. So it's not just Kalisha coming up with these ideas, it's a collective co-creation of a program, I think. I think it's going to be a program, some sort of a deliverable to give to people for them to test it. And then the last year or so of the grant is just finding another set of payers that didn't participate in the first part to try out what we come up with to see if it's going to work.
Oh, that's great. And then that will be kind of like a roadmap then.
Yeah, the cheat sheet, I hope. The roadmap. Yeah. Something that they can use to help them with navigating systems. And part of the reason I'm really interested in going across regions is that I know there'll be differences, but wouldn't it be nice to find some collective similarities?
Would be great.
Yeah. So that's the idea. And then, of course, to write a really big grant to pilot it across the US and multiple spots.
That's fantastic. It's such important work.
Thank you.
It really is.
I try. I love what I do. I truly love what I do. I get really excited helping people. I was on a call previously. I was sharing this with you before we got on it. She's like, what do you do for fun? And I'm like, fun. My work is fun. But that sounds really nerdy. Like, fun something else.
It doesn't sound nerdy. It sounds like you need, well, we all need an outlet, right? But if it's fun, then that's part of it.
I do really enjoy it though. Meeting people, hearing people's stories. Like, I really do love people. And so it's nice to just feel like I've helped a little bit, but I'm gonna have to figure out something to do. I mean, I have some self-care things like nails, hair, facials, massages, but
right.
Hobbies?
Well, and I'm sure when you're talking to people, because there's such joy, and I don't want to sound corny, forgive me, but
it's okay. I already said my work is my hobby.
Okay. Well, when you're talking to somebody who's older and you see that connection that you make with them because they don't have that opportunity.
Yes.
And it's like they're just talking to you, and just to sit there and be in their presence and make that eye contact with them and listen to them.
So powerful.
Yeah.
It's beautiful. I love it. And I have had every daughter that I have done this with has said, wow, thank you. Several of them have said, I didn't expect my parent to participate that much. I didn't expect them to share that much. I didn't realize they felt this way. And so it was really, I think, a nice thing for them. Research often takes so much. I remember one of my mentors saying, Kalisha, research takes, we don't give, we take. Oh, I don't want to be a taker.
No.
And so it's nice to know that, I am taking some information. I'm compensating you slightly for your time. But hopefully I'm creating this beautiful memory that they have with their parent. Even if it is just for, a little bit of time.
A little bit of time.
Hopefully it's a powerful, beautiful moment for them, because it is for me.
That's beautiful. Well, and it's also hard too, because with dementia, I think we all fall into that bin of, well, they're just sitting here. And it's not true.
It's not.
And you get to see that because
I do.
They come, and that's all it takes with dementia. And it's hard because there's so much that's lost, but there's so much that's left. And you have to, right?
Go ahead. Sorry. Yes, I agree. Sorry, I talk over people. It's my family's origin. I try to get better.
You're fine. Don't worry about it. I'm Italian. I'm used to all of it. Don't worry about it.
Got 3 conversations going on at once, and like you're talking in and out of them. But no, I don't know if I mentioned that I'm a clinician. So one day a week, I'm still engaging with dyads. And so I'm at the Integrated Memory Care. It's at Emory. It's an entirely dementia-friendly primary care practice. So we expect you to come in. We expect them to come in with a family member.
Wow.
Like if they don't come in with someone, we're like, wait a minute, what happened? Obviously the messaging was wrong. And so it is so nice to talk with the clients and their families and to just meet with them and mingle with them and hug on them and love on them if they'll let you. Sometimes it's not a good day and they're like, I'm over it. I'm like, you ready to go? Yes.
Yes.
And then they stand up and I'm like, okay, well, this is over. But other times, it just really is nice. And at the clinic, I see all, races and ethnicities that come through the door. It just really is. I truly enjoy what I do. And I don't know if I would have had I not been raised by my grandmother and grew up in this neighborhood of older adults and really developed this affinity for older adults and really wanting to see everyone the way I want somebody to see my grandmother.
Right. That's beautiful. And and I'm sure your patients feel that.
I hope so.
Sure
I got a couple that'll cuss me out every now and then, but it's fine. I deserve it sometimes.
Well, I'm wondering what happens when you can see that a caregiver is struggling.
Yeah.
What do you do in that situation? Because, a lot of times caregivers, they can't bill for us. They don't know what to do with us. And what do you do with that situation?
That made me think of 2 things. The first is I use the visits for the caregivers too. Usually I'm always going to talk to the person living with dementia. That will depend on their disease progression, how long that conversation is. Is it a couple minutes? Are they interjecting throughout the whole entire visit? And my visits range from about 30 minutes to an hour, depending on what's going on, which is really nice. Again, as a psych provider, I get to do a lot of talking. And so I sometimes take that visit to reaffirm them, to let them know that they are doing all that they need to do. We have an amazing social worker and nurses and nurse practitioners that work on the team. And so often they'll schedule time with our social worker, whose name is Jenny, or the nurses. We have 2 Elizabeths. So it's really easy. So they'll schedule time with them if they need to, depending if it's medical, if they're needing resources. And so it's more social work, or they're wanting to do some support groups that our social worker does. It really is a neat place to work and a nice practice. So that's the one thing I do. The other thing is I really wish there was a way that we could bill for both people. You know,
yes,
the caregiver comes in with their person, and we have a way to see both of them.
Yes.
Because caregivers do not have time to then make a separate appointment that leaves the person they're caring for, who knows where, adult day, you know.
Or not.
With a friend or not. Tries to, you know, they don't have that extra time to schedule appointments for themselves. And then we wonder why their self-care is so terrible. That's why. Right. Because we really haven't evolved in a way to say, you know what, while you're in here visiting with mom, daughter's going to be seen over here, and then we'll put the 2 of you together. You know, like there really needs to be a new model that looks at a way to do that. Yeah, not my area of expertise, but somebody listen to the podcast and figure that out. I won't even take credit. Just do it.
That's brilliant. That would be wonderful. And how many African-American daughters do you see that say, I really don't know how much longer I can do this, but I'm going to keep doing it because I can't do anything else. I can't place my mother. I can't place my father. How many do you come up?
Pretty much all of them.
Yeah. That's what I was wondering. What do you say to them?
We try to get a strategy. I will say some, so it depends. So there's some daughters who don't have siblings. And maybe their other parent has passed away. So that's the hardest situation because there really isn't a lot of an outlet.
Right.
Hopefully they're in a sorority or they have church members or somebody where they can get loved on and feel supported. Other times it's a parent and a daughter or daughters. And so it's like, I'm doing this as long as my mom is okay with us doing this, or my dad is okay with us caring for her. I'm going to stick this out and I'm going to do it because this is what they want for their spouse. Sometimes it's a group of siblings. And so then it's who is parents staying with? Like, how do we shuffle them across the siblings? How do we consider placement? But usually placement into a long-term care facility is the absolute last thing people want to do. And so you cannot lead with that as a provider or staff member or someone working with this. If you lead with that, you shut the family down. Yeah. Because that's not where they want to start. That's the end of the conversation. Yeah. And a conversation they much rather not have most of the time, but it's one that, again, depending on finances and situations and how many people can be a part of that, the caregiving team that ends up going that way.
Well, how can people find your study or get involved with your study?
Oh, I'm going to send you flyers.
Well, I will put them with my show notes. Is there a website or anything, or?
You know, I am working on a website. Okay. You can Google Kalisha Bonds Johnson. I don't think there's that many of us. Kalisha Bonds Johnson at Emory, Kalisha Bonds Johnson, Ph.D. That's how I find a lot of people I'm looking for. I'm like, oh, so-and-so, and put Ph.D. behind it. And then it usually populates pretty quickly. So you can email me, which is bonds@emory.edu. So my first initial of my first name, technically my maiden name is bonds@emory.edu. I'm working on a website. I do say the Decide Research Lab, so it'll be hopefully it'll have Decide in that website somewhere. But yeah, so I'm around. I'm on socials.
If you could share, I don't know, if you could give one piece of advice, what would it be?
That you are the consumer. If COVID taught us nothing else, When consumers don't go to hospitals, they suffer financially. Mm-hmm. So healthcare needs people. We need you, and you are the consumer. So if you are not getting your needs met, if your providers do not hear you, they are not listening, find somebody else if at all possible, because you need to feel heard. You need to feel seen. You need to feel like you can ask for whatever it is you need. You may not be able to get it. Again, we already discussed, you can't always get what you want, but you should always have the freedom to be able to ask it and feel like you're asking it in what I call a brave space. Safe spaces, we say we create them. I'm not sure we do. Brave spaces are where you feel brave enough to ask what you want, to say what you want, and it be okay. So if you are not in a situation where you're in a brave space with your healthcare providers, you might be with the wrong provider.
A big thank you to Dr. Kalisha Bonds-Johnson for being my guest today. For more information about her research or to enroll in her research study, email her at kbonds@emory.edu. I hope you enjoyed our podcast today. Head over to daughterhood.org and click on the podcast section for show notes, including the full transcript and links to any resources and information from today's episode. You can find and review us on Apple Podcasts or anywhere you listen to your podcasts. We are also on Facebook, Twitter, and Instagram at Daughterhood the Podcast. Feel free to leave me a message and let me know what issues you may be facing and would like to hear more about, or even if you just want to say hi, I'd love to hear from you. Also, a very special thank you to Susan Rowe for our theme music, the instrumental version of her beautiful song Mama's Eyes from her album Lessons in Love. I hope you found what you were looking for today: information, inspiration, or even just a little company. This is Roseanne Corcoran. I hope you'll join me next time in Daughterhood.